That was my son. Albany's your limit?
Hey, there you
REMAC REMSCO, no, it's Saratoga, but they didn't get the hotel employee for this meeting, so they.
All right, ladies and gentlemen, if we could please get seated, we're gonna try to get this started and see if we have enough people.
We have enough.
You guys can come to the big table. There's room. Come on, we're gonna need you. So
Sit at the kids' table, let's go.
come on, have a seat. There's seats over there. On that side.
Plenty of seats.
We're gonna need you, so that's why.
Do we have four?
We're gonna take care of it.
Yes, sir.
Okay. Well, welcome everybody to the new year. So just to make this clear to everybody, the executive committee got a correspondence from Dr. Isaacs, replacing the current or the former EMS fellows with the new EMS fellows as alternates to the OMA medical directors. So they will be read in prior to the roll call attendance, and they can be included in the attendance if needed. They are, so the former fellows were William Hauser and Sophia Gorgon, and they will be replaced by Connor Murphy, Anna Ivanova, Christopher Kuhner, and Oscar Munoz Seda. So they will be replacing the current fellows. So when we go through the attendance and go through the roll call for attendance, they can be included as alternates for the FDNY medical director. All right, that said, I will pass it over to Michelle to go through our roll call.
When I call your name, please say present. Robert Winchell. Joseph Schenker.
Here.
Michael Batch. Robert Ackerman. Laura Ivagoli. Stuart Kessler. Matthew Fink. Wallace Carter. Eric Cohen. Kelly Hastings. Kevin Mungel. Cindy Basilios. Grace Cacciola. Here. Dario Gonzalez.
That's Dr. Murphy's cover for Dr. Gonzalez.
Dr. Murphy will be covering for Dario Gonzalez. Buenaseda.
And we'll be covering for Glenn.
So
Anna Ivanova will be covering for Buenaseda. Bradley Kaufman.
Here.
Nathan Reisman.
Here.
Pamela Lai.
Here.
Nicholas Alexander. Doug Isaacs.
Here.
Kevin Ward.
Here.
Anne Marie Girgenti. Andrew Dahl. Allison Burke. Jeffrey Raybridge.
Here.
Lauren Kosterko. Reed Caldwell. Jonathan Berkowitz. Louis Marshall. Michael Redliner. Dominic Battinelli. Ephraim Rendon. Eric Blutinger. Paul Barber.
Present.
David Benelli.
Yes.
Mary Foote. Mark Cantor.
Here.
Ed Jarvis.
Here.
Nicholas Carey. Joseph Bowe. Sean Graves. Jessica Van Voorhees. Benjamin Zabar.
Christopher Kuhner will be covering.
Chris Kuhner will be covering for Benjamin Zabar. Matthew Harris. Robert Krupe. Arthur Cooper.
Here.
Yedidia Langsom. Anthony Shalish.
And Dr. Van Voorhees. Excellent. Okay, so we do have a quorum, so we are going to start the meeting. Like again, once again, welcome to those of you who are here. So first, I will entertain an approval of the June 18th minutes. As the minutes were sent out via email, has everybody had a chance to review them? All right, anybody? have any- Okay, thank you. Second, oh. So minutes are approved. All right, executive committee report. So number one, like I said, we got the correspondence from the fire department. I will go over the full correspondence report in a minute. The REMSCO office staff prepared a list of all of the members and their absences from last year. According to our bylaws, if you miss, I think it's either 3 or 4 meetings in a row, your seat is vacant. We are going to begin enforcing that. What I'd like to ask of the people that are here, if you have any EMS physicians or people who are interested, to please submit names, because I would like to get people here that are going to be interested, that are going to show up. It's sad that we have all these people all these physicians and members that are on the list that don't show up. And when that happens, it becomes very tight, and it's a very big inconvenience for those of us who drag our asses. Yeah, I said asses out here to come to these meetings. It's just not right. So we're going to go through the list. We're going to vacate those seats. And after vacating those seats, we will try to refill them. If these people who don't show up want to reapply, they are more than welcome to, but we're going to vacate those seats and open them up. Okay. I'm going to read the correspondence and then we'll go on to subcommittee. So Mary Foote, who is the medical director of the Office of Emergency Preparedness, is going to appoint Christine Chen as her designee to be the primary voting representative for Department of Health. She will continue to serve as an alternate. That does require approval, and then it goes to REMSCO for vote. So we will have to vote on that. Well, actually, we can vote on that now. It's a hand vote. Yeah, go ahead. Oh, so we do have to vote on it. It's a hand vote because it's not a protocol. All in favor of Dr. Chen replacing Mary Foote as the primary for DOH with Mary Foote as the alternate, please raise your hand.
Is Dr. Chen here?
Any abstentions?
I'm obstructing.
You're obstructing. Thank you.
Dr. Chen here by any chance?
Dr. Chen is not here right now, but I have a feeling that she doesn't know that she was appointed yet.
Also, we're supposed to distribute the CV or stuff like that. We discussed last year.
So this is an appointment from DOH. It's similar to the fellows. So we just have to, again, it's an approval. It's not that it gets voted on. It's not an at-large seat, which we fill independently. No, he was just
obstructing.
Dr. Benelli. He's very obstructive. Dr. Caldwell has sent correspondence that he will not be attending, but Dr. Berkowitz hopefully will be here. Robert Ackerman, Glenn Asada, Stuart Kessler, and Mike Redlener, and Dr. Krupe all asked to be excused. The fellows we mentioned, some enforcement items. James Wilkinson of Syracuse, New York. Certification number 458352 is revoked effective September 4th, 2024. A civil penalty of $6,000 was assessed. $4,000 is stayed pending same probation period. The probation period is 3 years. Louis Carrillo from Corona, New York. State number 272873 is surrendered effective 8/7/24. Andrew DeWolf, Lyons, also New York, Lyons, New York, I'm sorry. 232200204 is revoked effective 8/26/2024. Assessed a civil penalty of $26,000. Yvonne Day from Roseville, New York. Certification number 416 186 is suspended for 1 year, effective 8/24/21/24.
Several
Um,
things.
Assess a civil penalty of $2,000. I apologize for my long-winded ranting. Harold Serrano of Bronx, New York, 449,474, suspended for 1 year, effective 8/20/24. The suspension is stayed pending successful completion of 3 years of probation. Assessed the civil penalty of $4,000 with $2,000 stayed pending the probation. Amanda Uji from Walkhill, New York, 256,221, is suspended for 1 year, effective 8/20/24. The suspension is stayed for a 3 year probation, and the civil penalty of $4,000 with $2,000 stayed pending successful probation. Brian Torres of Spencerport, New York, 14559, is suspended for 1 year for violation of a previous probation. James Schoenfeld of New Paltz, New York, 386,652, is surrendered effective 7/15/24 for violations and violation of a previous stipulation in order. Koido Saito from East Northport, New York, 473,647, is surrendered effective 5/13/24. Benjamin Miller of Messina, New York, 307,329, is revoked effective 7/3/24. Gary, I'm gonna mess this name up, Radijak from Oneonta, New York, 273,857, is surrendered effective 7/2/24. And Laura Panaro from Greenville, New York, apologize for the spelling, Laura, 194,997, is surrendered effective 6/5/24. And these enforcement items can be seen at the New York State website. Okay, a couple of ambulance companies, Jamaica Hospital and Northwell Health, have requested more information on the ultrasound pilot document that was sent out. The region sent out an advisory, I believe it was last month, outlining the findings of the tag, which is that we are interested in ultrasound pilot project. They would have to be submitted to the state as a pilot project. They showed interest. We haven't heard anything more. There's also a physician who is trained in point of care ultrasound who has indicated a interest in training people in point of care. For those agencies who are interested, they can contact the REMSCO. We'll make this person's name available. And that is the correspondence that were received. Any questions on the correspondence? I apologize for my long-windedness. Okay, so we'll move on to subcommittee reports. CNC, Dr. Barbara. Please don't forget to speak into the mic. Charlie, maybe tell you.
Speaking to the microphone is an ethos for me. Don't worry. The CNC committee met on August 15th, 2024, remotely. Items of discussion are the ongoing credentialing, physician credentialing process. That's the most active item with transition to the learning management system. A couple of action items are brought up, which were forwarded to the Medical Standards Committee, including the closure of the final date for recertifying without an actual class for all the pending semi-expired providers that are in the infinite nebula we have out there, which will be October 31st, as voted on by the last Medical Standards Committee meeting.
Why don't we discuss that, because
Okay, that's the first item. Is
medical standards.
so then the first item, I guess, came up in here in Medical Standards is the sunset date for re-credentialing of an expired provider in the online medical control certification in New York City, moving from September 30th to October 31st.
What was the thought
This
behind that?
this comes as a second in motion from medical.
Correct. What was the thoughts behind that? You want to just discuss? it a
I'm
little
sorry,
bit?
so the rationale behind it is that when we moved from a 5-year cycle to a 3-year cycle, the price Do I need to press on this? Oh. It's still up.
There we go.
Okay.
Thanks very
When
much.
we move from a 5-year cycle to recertification to a 3-year cycle, the fee that was for 5 years was $200. If we would have prorated it to 3 years, it would have been $120. We requested that the REMSCO Board of Directors set the fee at $150, so a little higher than the $120 that would be appropriate for a 3-year cycle. The Board of Directors elected to keep the fee at $200 for 3 years. Since then, I have spoken to a number of members of the Board of Directors and the Executive Director of REMSCO, and it seems that everyone is inclined to reconsider the fee to be $150 for recertification. I think Scott can add on more to that. It is not a significant difference in price and cost for REMSCO and the global budget that REMSCO has. I believe it's a $2,000 difference you mentioned, right? The Board of Directors, I believe, is meeting on September 26th, and not again, correct me if I'm wrong, and not beforehand. And that would leave very little time for physicians who don't want to pay $200 and want to pay only $150 to actually do the re-credential. Therefore, we suggested that instead of making the sunset date September 30th, we'll make it October 31st. Give time for the Board of Directors to weigh in again and reconsider, and then that will be the final sunset date. And moving forward, I believe, Paul, that you said that that will be the sunset date for all re-credentialing moving forward.
Yes, that the logistics of the cost as well as the logistics of when the calendar year starts and finishes is actually to facilitate the REMSCO staff from having to track people down, which was how we got to this problem in the first place, which is several of our own doctors didn't know they were expired. So the transition to the learning management system involves a lot of logistical changes, one of which is likely to be a single calendar day, which every physician will expire based on their 3-year cycle for this cost that's being negotiated, as Dr. Benelli and Scott had spoke.
So just, I know that there's, I know that this does come as a second emotion. I just think we should listen to Joe, who has to do the back end. He had some very valid points about having everybody expiring on the same day. Go.
Thank you, Dr. Shanker. Yeah, so since the Medical Standards Committee met, staff has been looking at on the back end how to implement the idea of every position expiring, or depending on their year, having 1/3 of each of the positions expiring on the same date. We actually recommend against doing that for the reason that then you would have all of the positions that are expiring that 1 year, all submitting their paperwork at the same time and inundating the staff with their paperwork. And also, it also makes it so that if there are any errors or anything that occur within the LMS itself, those errors will now affect all of those individuals trying to recertify at the same time, versus if we get them periodically over time, any errors or improvements that we need to make, we're doing them with small batches incrementally at a time. So we would adhere to whatever decision the committee makes if they feel that it would be better, but we would recommend adhering to positions, maintaining staggered expirations, of course, tiered to the end of the month of which they're certified.
So basically what that would mean is that obviously the price and an October deadline for this first is number one and is a priority. But going forward, you would expire, let's say if you recertify in September, you expire at the end of September 3 years later. As opposed to everybody expiring October 31st, it would roll to the end of that month for the purpose of giving you the complete month, but at the same time maintaining some reasonability for reasonability.
I don't believe that anyone on the,
right?
I don't believe that anyone on the committee had any It should be wanted to make life easier.
Correct.
If it's not
Yeah,
making
and-
life
and-
easier.
And we didn't have that input,
Yes.
which I would say trumps anything we said up till that point.
I agree. I
Because
think
Joe is the heart and soul of the LMS, and what he says is gospel as far as I'm concerned.
I'm just trying to save this meeting.
Yeah, no, I think if we can make all the suggestions we want, but really the practicality is up to you guys. And if you feel that strongly, perhaps a quarterly based on letter of the last name, or a month, you just renew on the end month of
Right.
your.
I will tell you that a lot of this feedback came from me going through it and doing it and talking to Joe and Dina, because a lot of us are probably expiring at the end of September, and we probably should get on the LMS and do our renewal. Really easy process, but it definitely needed a few fine tuning is what I found when I was going through it myself.
And we are aware of the current issue with physicians. If, you have until the end of September, if you expire, if you renewed in August, you lost that month. We're working now to correct that and to ensure that that is corrected moving forward. So we just got to make some tweaks to the system, continuous improvement.
So essentially, David, would you be willing to accept the motion as just about the expiration date for now? And then we'll figure out the future expiration dates for everybody. But for right now, I think we need to move the expiration to October so that people can find out what the board is gonna say.
Yeah, Paul, I have no issue with it unless you have.
No,
Okay. Motion to extend that expiration date by.
that's the motion.
That's what we're
That's the
doing.
motion. Okay, very good.
Yes, so the motion is to extend the expiration date for expiring positions from September 30th to October 31st. And then we'll vote. And we'll move on back to the report. Whenever you're ready. September 30th to October 31st. Correct.
Prior to.
Either already expired.
Right,
or-
we
Yes.
gave everybody that sunset date, now we're gonna move it forward. So that is the clarification, that's exactly it. Correct. Scott, did you want to add something? That's what-
No.
Dr. Barbara, came in seconded for medical staff.
Yes.
Did everybody have a chance to sign the attendance? Yeah. Did everybody have a chance to sign in if you weren't? Yes, I agree. We just, all in favor of extending this, it's not a protocol, so we can do it without a roll call. Please, you can just, you don't need a roll call, but we need to write it down. Please raise your hand. Try to make it easy. You have two hands up?
Yeah.
It's obstructing again.
I'm not voting unless I need to.
One abstention, all abstained. 15 in favor is good. The whole one that's
And you abstain?
He's abstaining. 'cause he's
Yeah.
a pain in the ass.
This is inter-
Write that down. Write down, pain in the ass. Okay, Dr. Barbara, back to you.
The other agenda item it's pending is the other point of discussion was removing the requirement for ATLS, PALS, ACLS, and BCLS credentialing for any renewal OLMC candidates. Essentially, just to explain that, if you've already gotten your medical control credential, you're not EM board certified, you would need to have ACLS, BLS, PALS, and ATLS. That does not, we discussed this here, and it was felt that that should not be a requirement to maintain active cards in those disciplines to renew your credential. We're not changing the path to initial credentialing. It's simply for the renewal candidate, because those medical changes are incorporated in our protocols. For instance, when ATLS changes something, we change our trauma protocols. When BLS changes something, we change our EMT protocols. So by the nature of being protocol competent and up to date on our protocols, you shouldn't need those cards moving forward to renew. And this was felt to be an obstacle to maintain practical staffing and HR issues at some of the medical control facilities in the region.
Any discussion?
Yeah, I mean, the same requirements to get your certification should be the same ones that you maintain, regardless how we're changing our protocol. So just because of research should be the same standards. I think the only exception would be if you're EMS board certified or emergency medicine board certified, then kind of like, I think the other
So
said, in
the merit
maybe not
badge-
having that certification.
The merit badge cards, ACLS, AHA, ACLS,
Yep.
BLS, PALS, and ACS, ATLS are not required to gain OLMC credentialing if you are EM board certified. They're the caveat for those who are not EM board certified. And the suggestion was, again, just want to make sure I'm clarifying it, that if you've achieved initial certification, you don't need to maintain those cards to renew your credential for medical control.
So basically what you're suggesting is that for a non-emergency medicine board certified individual, they would not need to maintain their certifications.
No, just
They would not need to maintain, yeah. the
Those-
answer is correct.
those 4 cards. They would
not
need to, they would need to maintain their board, et cetera.
Okay.
That's the
Any
suggestion.
other, so
I presume that, the waiver requirement applies to EMS board certified as well as EM certified.
Yes. Dr. Cooper asked if it applies to EMS board certified as well as EM board certified. So yes, EMS board certification trumps everything.
Yeah, so just so I'm clear, if you're not EM board, you had to do those classes.
Mhm.
That should be the same for research for non-EM boarded people, right? So you're saying that it won't be
No,
That was the suggestion.
the suggestion.
We're gonna
So
vote
I-
on it here.
I agree with what Doug said. Not EM boarded, you should maintain this.
As non-EM boarded.
You're EMS boarded. Yeah,
EMS.
I thought our.
EM or EMS
EM or
counts.
EMS.
David,
we need to remember what the rationale was. Well, we said that once you do the initial certification, you don't need to do it again. The rationale is that through our protocols, they will remain updated. And they do not need to be recertified, and we do not need to make recredentialing for control positions who we are struggling to recruit to make life even harder. So that's why we suggested that, yes, you need to do it initially, you need ACLS, PALS, ATLS, etc. But once you're certified, we would like to hope that our protocols they would remain updated with what's needed in order to function as an online medical control physician. We don't expect anyone to be a trauma surgeon.
thank you.
Then why have certification altogether? Just because.
I'm saying you need to meet a certain level initially, and then you maintain updated.
Should maintain that same level of certification.
They're both valid points, but we'll discuss them more.
This is a point of clarification. What is the breakdown of all of the yes, so it's just for my own.
Let's answer that question after October 31st.
Well, but in the current, I mean, like, is this
There's a,
a problem that requires?
What is, you know what the number is roughly?
I would refer to those people as critical access positions who work a niche that requires being worked.
Yeah.
They're few, but they work.
Solution looking for a problem is what we're asking.
Just to clarify, the whole point of this discussion was that the physicians being applied the same protocol updates as the paramedics should render the information being transferred in the same fashion. At no point is there an urge to reduce standards. If anybody knows me, it's not how I play the game, right? We're enhancing standards. By holding the physicians to the same standard, it actually will be an impediment for some medical control facilities to staff their required staffing hours by making their providers go through ACLS, BLS, PALS, and ATLS on a cyclical fashion when we're giving them the same information in our own regional protocol updates. That's the cards on the table.
I mean, I know that most physicians who work in a clinical area Other than, actually, even for sort of like. If you work at a trauma center, you have to. And you have to do it. But unless you're the trauma medical director and the PM positions who are ordered in EM, do not need to maintain, they need to renew every time. But I mean, that is part of credentialing most hospitals on a 2-year cycle, so. Sorry, that is credentialing in most hospitals on a 2-year cycle. Yeah, go.
I think some of the rationale behind it was for the online medical control positions have been, the idea is that once you do online medical control, you are running cardiac arrest and you're providing medical control for that over the course of that 3-year certification. And that's going to give you that your ability as an online medical control physician than taking a potential hybrid 4-year, 4-hour ACLS course, or a PAL certification.
Right.
Of course, that assumes the person's active and working online medical control. If they just been maintaining it, haven't worked many shifts, then maybe they're not getting that.
Right, and that's the assumption, right? So those of us who are EMS boarded are doing this day in, day out, running arrests and involved in care, and it's unclear that subset of physicians, how much actual clinical practice in that arena they're doing, other than maybe some occasional medical control shifts. So.
Yes, David.
The
and we're
assumption
gonna wrap
is
up
that
this
those
discussion.
physicians who already were credentialed. Yeah. Will have sufficient on the online medical control.
Based on what?
I'm not sure that they're gonna be, based on the updates from, DCNC.
No, but I think that Dr. Bradley was saying is that physicians who are having to maintain this, whether they're EM boarded, working in the emergency department, or EMS boarded, are routinely doing cardiac arrest. So they routinely have the ability to maintain their skills, and therefore there is a logic to why they're not required to maintain the certification, even though they're maintaining the protocol updates. But if you have a physician who only is seeing a protocol update, but never running a resuscitation, maybe the extra support of having that course is indicated. And like I said, I think a lot of these physicians were worried about them being overwhelmed, but a lot of them have to credential in their other jobs in most cases, have to do this anyway.
Absolutely. The question is, what are we expecting them to do? Are we expecting them to be a doctor? Are we expecting them to be Olympic physicians? The current protocols, they probably are able to function as holistic physicians, and they probably do work as an holistic physician, not to the extent that they're in the resuscitation bay and providing intervention, but to the extent of managing the product.
Okay, so I think I'm going to take Brad's comment and then we're going to.
Well, this, I mean, someone mentioned that most re-credentialing now requires that, but I know at the facility I work, they do not. And I
For
think
non-EM, not
for,
re-credentialing on PALs and ACLS.
does not require. it.
Even if you're.
Or EM. A lot of places do require it for non.
Oh, well, I don't think for anybody because they have their own ongoing continuing medical education. And I think it's important to keep in mind that having these courses and taking them, they, I don't think are necessarily providing what you may be thinking them, right? So, like, I think it's a hurdle that in many cases is a low or no standard. So I would support that it's not really really changing our standard if they're keeping up the other CNA.
Okay. I think that was a great discussion. We're going to vote on this. The vote is the motion is to remove ACLS, BCLS, PAL, and ATLS for non-EM/EMS boarded positions as a requirement.
Research.
All right, and when you hear your name, just yay, nay, or I don't want to play. This is from CNC.
Michael, you can please say in favor, oppose, or abstain. Lana Zeta, Bradley Kaufman,
Opposed. Wait, I'm sorry.
Yeah, you don't know, wait,
Opposed is that you should maintain certification.
yeah, which is not.
No, no.
So you're in favor.
Okay.
He's in favor of removing it. Correct. All right, next.
Terry Gonzalez,
Who's Dario? Yeah, we know the- Murphy.
Somebody say something, somebody say something nasty to me, that's that.
Murphy.
So we already did there. We did.
He was glad.
Opposed.
All right. What did he say?
He said opposed.
He's like, I'm a big guy.
We have to be arguing.
Well, that's it. All right.
I really hope that was on the.
Favor.
Opposed.
Graber,
Opposed.
Reed Caldwell or Jonathan Berkowitz, not here. Louis Marshall, not here. Michael Redlener, not here. Joseph Schenker. Joseph Bo, not here. Arthur Cooper. Robert Winchell, not here. Ed Jarvis. Mark Cantor,
Opposed.
Robert Rippey is not here. Mary Foote is not here. Laura Everpoli and Stuart Kessler are not here. Matthew Fink and Wallace Carter are not here. Kevin Gel, not here. Cindy Vasilios, not here. Matthew Harris,
In favor.
Jessica Van Voorhees. Benjamin Zabar,
Opposed.
Paul Barber,
Abstain.
David Benelli,
In favor.
Eric Blutinger, not here.
Yeah, so there are 6 in favor and Michelle is going to count the opposition, but being that we are at a quorum, 16 is the quorum, all would have had to been in favor for the vote to pass. So the vote does not pass and the standards are fixed. Back to you, Dr. Barber.
Mr. Ward has the remainder of the CNC.
We continue to update the exam with the upcoming protocol changes, swapping questions out that no longer apply. Recertifications through the CME process continue. We're doing about 50 to 60, I would say, every 2 weeks. It's becoming easier. I think everybody's starting to get a hang of the process and all is running smoothly.
That concludes the CNC report. Thank you.
Just to be clear, so that everybody understands, the way the rules work for meetings in New York State with the public meeting law is you must have a majority of board members, not a majority of the people at the meeting. So in order for a vote to pass, it would be a majority of the total, which is the quorum, and that's why the vote did not pass. Okay, medical standards, Dr. Benelli.
Okay, so medical standards met a week ago virtually. We had a strong attendance because it was virtual. And people did not have to battle traffic to arrive to 120th Street in the Upper West Side.
Wait, was it virtual? I'm
It was
confused.
virtual. I don't know
Thank
if
you.
I mentioned that. Yeah.
I just learned that arraignments are done virtually, so I wonder if we can push the agenda a little bit more. Because arraignments are now being done virtually in the hospital. Art,
I will hold my report for Art.
I will remind you that.
sorry, Art, you should just hold the mic on your lap.
Yeah.
Yeah.
I will remind the group that I did bring this up some time ago about writing a letter to the commissioner saying that we're all emergency providers and, you know, to drag us together through hours of traffic to get to the Upper West Side, as my colleague has pointed out, is potentially a waste of time. There's no question that getting together every now and again is helpful, useful, and that could really controversial items where an in-person discussion is necessary, but I do feel that it's worth bringing this up again, trying to get some relief on this particular point.
Thank you. I would ask Doctors Isaac and Ravitch, who will be at REMAC next week, if they could please bring this up under new business, because I think that it's definitely something that we should push the agenda on, especially if other you know, official things are happening virtually, we should be able to do this
Yep.
virtually as
I
well.
agree with it. The answer we get often is refer to the New York State Open Meetings Law, but we will continue to.
Excellent. Thank you.
It has been actively discussed as most, including CMAC as well. But
That's
again,
that forum
you have to correct, change the law, so. Active discussion, but well, I'm not sure of the act. Thank you.
All right, Dr. Manelli, if you would like to tell us about your virtual meetings, please.
Okay, so we had a similar discussion that we had here regarding the CNC report. No need to repeat that. Protocol committee brought up the rest committee protocols. That's the only action item that's being brought to REMAC, a second in motion. There are changes to the rest committee protocol, which I'm going to allow Dr. Lai and Dr. Isaac to review and explain, and then we should vote on it.
Charlie, could you help with the projector, please?
While it's being put up on the screen, these are just modifications or changes to the existing protocols. Particularly the blood transfusion protocol was, approved at CMAC with 2019, I want to say. And we had written them a couple of years prior to it, and this is just an update based on some of the experience of 23 other cities in the US that currently have field blood transfusion. As many are you aware, again, while the protocols were going to go up, Public Health Law 3005 was passed. The changes initially was just for it was medevac to distribute and allow medics to transfuse blood. And wording has been changed to existing public health law to include ground transport as well. It has passed the the state House and Senate, and it's just waiting for the governor's signature, which we believe hopefully will be this week or next week. It's our expectation.
I just want to keep this before Dr. Isaac goes through the protocols. These are specialty protocols similar to the protocols, especially other specialty protocols that we have already approved for ESU, for HAZTAC. These are rescue medic protocols. They're only for rescue medics. They don't apply to the entire system. These are only for Dr. Isaac will discuss blood transfusion. It is only for scenarios where there can be extended extrication. We all understand and agree that if there is no extended extrication, trauma patients should be brought as fast as possible to a trauma center, and we have plenty of those, 17 now. Okay, sorry, go ahead.
Thank you, Dr. Benelli. The first part before we get to the actual medical protocol is just a GOP section. There's really no change in blood components, just the change of order, really preference. Carrying whole blood, and so that's why it's on top. We also just made some changes that, one partner with Health and Hospitals, as well as we'll have a true portable blood refrigerator as opposed to a temperature insulated container. And so hence, those changes there. And then we just changed instead of trauma, we just made we required 2 identifiers, and so if we have unknown name of a patient, we had trauma stat, but we changed that to unknown. Now just some of the changes. It wasn't just to the blood, in terms of blood transfusion protocol, but also to the existing GOP and rescue medical protocols. One here, we've had antibiotics in there for opening or penetrating wounds for delayed transport. We had it as a medical control option, and we just moved this up to standing water. We've had this protocol out for since 2019. And just, for time sensitive administering antibiotics, we just move it up to a standing order. Okay, now getting to blood transfusion protocol. Also would just like to also thank our EMS fellows as well as Matt for feedback, and particularly to the pediatric component of the protocol. So we didn't really change in terms of the indications. The main thing was adding pediatrics, as well as we just changed the wording for the positive fast exam in terms of the heart rate and blood pressure. For the pediatrics, we had the age-defined minimum systolic blood pressure as well as age-defined tachycardia, and we have a table for those minimum standards. And just to make it clear, those not changed. These are really for delayed and transported patients. We're very fortunate in New York City to have so many trauma centers. So if we can rapidly transport a trauma patient suspected of internal bleeding, we're going to rapidly transport them. But this is any delayed transport, as well as being able to support other agencies here in New York City, depends on the circumstances. So in terms of for pediatrics, we added the less than 35 kilos. So the first option priority, which we'll be using whole blood, it'll be 10 mLs per kg. If we're not able to have whole blood available to us, we'll be giving plasma and packed red blood cells in those orders, and it'll be 10 mLs per kg for each. And then for 35 kilograms or greater, we'll treat them as adult, and hence a unit whole blood. Or option B, plasma 1 unit and packed red blood cells 1 unit as well. And then transfuse additional doses if needed clinically. The other additional change is the calcium. We had before had 1 gram of calcium chloride and calcium gluconate. The literature does indicate, not even regarding blood transfusion, but trauma patients alone, they're hypocalcemic, but also with given blood products. Even though the evidence is really not overwhelming in terms of giving, because the elemental calcium gluconate paired to calcium chloride, as we all know, it's 3 times elemental calcium chloride. We asked the question about giving 2 grams at least to calcium gluconate. So looking at protocols and even again, it's evidence is not strong, but in terms of best practices out there with the military and other EMS agencies around the country, we had decided that 2 grams of calcium gluconate and keeping the 1 gram of calcium chloride. In addition, because we added pediatrics to this, we also had to add pediatric dosing for those with allergic reaction, and hence we added the pediatric dosing for the existing medications in order to treat those with allergic reaction from the blood transfusion.
Can I just ask a clarifying question? and forgive me, this may have come up earlier, are we pre-treating or responding to symptoms? Are we pre-treating
No,
or responding?
responding.
What was, what was, I'm not looking for modification, but what was the thought? We pretty routinely pre-treat with children prior to blood. I'm not sure that there's an evidence base or if that's just common practice, to be fair, but it's one of the ways that for consideration.
It's just for the time sensitivity, we could, given because remember, we're not gonna be treating back to ambulance reality in our world. We might be treating under subway or some other delayed transport. So, and if we're starting this treatment that they have, signs of deterioration, so we want to sort of blood products while monitoring. The other thing that we did add here is we do have for trauma as a staying water blood transfusion. And I just also want to preface it that we do have a QA committee that's set up with H&H Trauma as our partner, as well as OMA, and we're still working on identifying the stakeholders. We're going to meet on a monthly basis. Even if we don't administer any blood products, just want to avoid wasting a precious resource. We are rotating the blood to avoid any wasting of blood products. The other thing is we did add, unlike
all cases going to be cured.
yes, we're gonna, yes, every administration, but even on a monthly basis, even if we don't administer any blood, we just want to make sure that any blood products are not being wasted.
So the summary of any QA be sent to the REMAC QA committee?
Yes. Everybody does, in addition, we initially just had this for trauma. We do has the standing order, but we also added an option for medical, but that would be for those for medical etiology bleeding. However, we made it as a medical trial option. They must speak to one of the primary physicians, the MOMA, the response physicians, in order approval to as opposed to trauma. Outside of blood transfusion, go to our compressive syndrome. Some of the reasons for calcium dosing. We add this also we change some gluconate from 1 gram to 2 grams, and while maintaining the calcium chloride at 1 gram. Also, 2 other changes in the protocol. We removed mannitol. While there is some evidence support in osmotic diuresis in prolonged field operation for compressive syndrome or perfusion syndrome, it's not overwhelming evidence. We have never used it in the history of our program, nor in the history of FEMA Urban Search and Rescue, nor I'm familiar with INSRAG, which is International Search and Rescue Group. While also having difficulties maintaining it, tends to crystallize it, and then you got to resuspend it in a warm bath. So at this point, since it's never been used, and just might be good academically, but in terms of real world, we decided to just remove from the protocol. As well as the next protocol, the last change is in pain management. Every state or limits how much fentanyl that a obtain, would have to ask for the increased amount in order to carry the fentanyl and transglucose. I've still been working on that, but realizing and looking at the medical literature, speaking to those who operate in that environment, because with some activity, your mucosa tends to dry out and you don't really get a good delivery of the fentanyl. So therefore, based that we don't really have it and based on feedback from the military, that we decided just to remove it from the protocol altogether. That is the changes. Any questions?
Any questions?
Any discussions, questions?
Hearing none, we will vote on these protocols. So the next vote is the rescue medical. All right, when you hear your name, please yay, nay, or
Anyway.
Anyway.
For obstruction. Now she see it.
Bradley Kaufman,
In favor.
Erickson Dawes. Nathan Reisman,
Favorite.
Pamela Wise,
In favor.
Nicholas Alexander.
Yeah.
Doug Isaacs,
In favor.
Jeffrey Raybridge,
In favor.
Jonathan Berkowitz. Louis Marshall is not here. Michael Redline is not here. Joseph Loeb is not here. Arthur Cooper. Jarvis. Mark Cantor. Robert Ruby is not here. Here, Laura Everett, Kessler, are not here. Not here. Kevin Mandel, and Stephen Stevens are not here. Kevin Voorhees. Benjamin Zabar.
In favor.
Paul Barber.
In favor.
David Murphy.
Yes.
Motion passed.
Okay.
That's a good
We're gonna
question.
try.
We're gonna try. It's gonna go up tomorrow and hopefully we'll make the cut, but I don't know.
CMAC is on the 19th. When is it?
Next week.
Yeah, 18.
18th, yeah. Okay, good luck. The last thing that I don't know if we need to discuss as part of the medical standards report was this table that Michelle sent around and Dr. Zabar updated. The formulary, the REMAC formulary protocol medication list, not formulary, but medication list. We can do this now, we can do this later, and I can conclude my report if we want to do it later.
So, I know Dr. Ben isn't here, but Brad, just to clarify, this is just adding to the table, the same format that we used previously, any new medication that are included.
Yeah, so this is just the previous medication list updated with protocol that went live October 1st.
Thank you.
We don't need to vote on this one, it's just an
I
update.
think we can just accept this as an update to the medication list.
Good.
Does anybody have any questions on it? It was mailed out. Is there any questions to the medication list? At all? Here in the room, we will accept the update and
Good. That concludes the medical standards report. The next meeting is on October 1st at 3 p.m. No need to travel or drive. It will be virtual.
thank you.
Thanks.
Okay, the Q&A report. So, administrative update first. Dr. Redletter has asked to step down as chair of the QA committee. He will be replaced by Dr. Turco. Oh, sorry. So, Dr. Redletter has asked to step down as the chair of the QA committee. He will be replaced by Dr. Turco. He will remain on the committee as a member, but Lauren will take over as the chair. So we welcome her and thank her for that responsibility. And then I'll give it to Joe for the QA report.
Thank you. Much of the QA's last meeting, which occurred last week on the 4th, much of the discussion centered around expanding the utilization of First Watch within the region. So some action items that the committee will be taking with that regards is that we'll be setting up a series of forums for the First Watch users that have access to the dashboard so that we can give them some training and some insight into utilizing the dashboard and manipulating the data on there. We'll also be setting up soon some monthly spotlights to send out to, again, the the users on First Watch so that they can focus in on some of the data, do a spotlight of it, and compare some of the data from their own agency to that of the region, as well as do some quality assessment of the data in the first itself. The committee started strategizing about different ways to reach out to the various agencies on this, including emails, setting up the forum, as well as providing Q&A sessions. We'll also be looking at very closely the New York State quality measures as well, and doing on that. And the committee is also looking at reaching out to the New York State Department of Health, who is planning on rolling out a new data analysis tool called Biospatial, and seeing how we can leverage that for our work as well. And that concludes the QA report.
Thank you. Any questions for Joe? Okay, training and education, Morty is not here. REMAC meeting. Unless there's somebody here who'd like to give a report. Okay, nope. Dr. Berkowitz, inter-facility transport.
Yeah, so
No problem. So we will anticipate your report next month. Thank you. RTAC, I don't know if they met, but I don't know if there's somebody here. They did not.
We're meeting in October.
Excellent. Okay, so we'll wait for the October meeting. Regional Council, at the end of June, how they report to us. Basically, they have approved the transfer of operating authority from Project Volunteer Ambulance Volunteer Ambulance Corps, now known as Gotham Volunteer EMS. Some reappointments for another 4-year term for Greater New York, emergency management, and H&H. The following at-large members were approved: Benjamin Fay, Michael Combs, Marie Diglio, and Oren Barzilai. Some completed applications for course renewals were received. They are Borough of Manhattan Community College, Code 1, Emergency Aid Training, B&H Emergency Medical Training, NYU Langone Health, Montefiore Institute for Emergency Care, LaGuardia Community College, Emergency Care Programs, FDNY, and Queensborough Community College. There was a regional kind of specialty course sponsor application, which was approved. A tag to address recruitment and retention in EMS was formed. The tag members are Marie Diglio, Michael Combs, and Arthur Cooper. Scott Chang reported the office.
Stay.
It's all right. Don't worry about it. We'll let you know. A recruitment and retention tag. There you go. Well, you'd be good at it. Scott Chang reported that the Office of the Regional Council is exploring a high-quality health insurance option for EMS professionals through private insurance companies. And they will also be able to remember the report of the Office of the Regional Council and agency contract, which will be renewed as of July 1st. The state added additional $15,000 for recruitment and retention efforts and $20,000 for scholarships. That's pretty much it. The memorial is scheduled, the EMS state memorial is scheduled for September 19th. And the next meeting will be on September 24th at Randall's Island. That is the REMSCO report. I also want to announce over the summer, next meeting on September 24th is at Randall's Island, correct? The building is undergoing construction, so we don't have the room as frequently as we could previously. So some meetings this year, you really have to look at the calendar invites because they're not all here. They're at Greater New York, they're at Fort Totten, they're at wherever they might be and needed to be so we can have the meeting. You're welcome. Okay, there also was a tag formed over the summer to review the Part 800 changes. That tag met. They made recommendations which were sent out to the whole committee. And I believe that the letter is going up today or tomorrow,
Or
or when yesterday.
Yeah,
Or
the
when I-
closing comment period was yesterday.
Correct. So it did go out for the closing comment period. Most of the comments focused on legal services. Themselves. There were a lot of requirements that were added. Frankly, don't make sense. The fact that we're there were some sense that every day were added. Ambulance service having privilege. That makes a lot of sense. That was included in our. See where it's going, but and I don't know who.
There were some good changes like the equipment, the total city, but used on board, but now. Yeah.
Yes, so the comments that were sent out. That is the rest of there was no feedback the next week. So we will anticipate a feedback from both Dr. Beveridge and I. Any unfinished business that everybody knows of other than that? Yeah.
Just like to announce our conference for the spring.
Okay.
Let's give people advance notice, April 24th to April 27th, at the NY Medical Special Operations Conference. So
Does not coincide with the Jewish holiday, by the way.
yeah,
I wondering.
I double, triple, quadruple checked everything. So
Okay, final item under new business, actually the first item under new business, in case anybody didn't know. We're back to the topic, the term for officers. That term will expire in June of 2025. So we're in the process right now of putting together a nominating committee and going forward with our new election. The bylaws do not have term limits, elections, which in my mind is the same. So I have asked that it is accepted by the chair our nominating committee. Dr. Reed volunteered for that committee and I volunteered Dr. Harris. Thank you. So the three of you will be the nominating committee. The current slate of officers will be myself, have submitted to the office. The nominees will be announced in January with a repeat in February and vote in March. That is how the bylaws work. It has to age and then it can be voted on. So the vote will be hopefully in March with the new officers or the current officers, if they're not reelected, to be live as of July 1st. Any questions on that? Because last year there was some concerns that we didn't do it 100% kosher, and I want to make sure we're doing it right. Okay. Any other new business? Yes.
Are you going to discuss ultrasound at all or no?
So, that is a good point. I apologize for not bringing that up. We did have an advisory that was sent out last month based on the ultrasound committee, the ultrasound tags, findings, suggesting that it is a good modality. It should be discussed. It should be piloted. There are agencies that have shown interest. Northwell, Jamaica have shown interest in pilots in ultrasound. The pilot project process is you would have to submit a proposal to the region. It's kind of like an IRB. You'd have to have your IRB approval and your project from your parent organization or whatever that might be. Would be submitted to the region and then approved at the state level as a pilot. There is a pilot project rules at the state level, and we can go forward with that. Yes.
actually, Joe, I don't think that's actually accurate in terms of the state having approved, in terms of The particular pilots, I know that was instituted during the John Freeze relative time. The state pilots, this is not a treatment modality. It's just an assessment tool, and I don't believe that this actually has to go to the state as a pilot. More of a region though, again, this is not a treatment modality. The point of the tag, the ultrasound, is just to support other agencies, share best practices, training, and what have you. As part of the system.
We have to ask, but I think that the concern that I have is that if you are piloting or doing a study on not feasibility, because we know it's feasible, but how we would use and apply ultrasound in our region, that would affect a lot of the transport times, like we're in our protocol. I think that is an inherent protocol change. That would not be a protocol change, but we'd have to pilot it in the particular protocol, and therefore it would fall under the pilot project rule. That's just my opinion. We'd have to ask for more clarification. Arthur. Cooper.
Yeah, please just bear in mind, this is a rapid transporter system. You know, S is faster than CT, not that fast, you know. S exam is 3 to 5 minutes, okay, as we all know. You know, not to mention the fact that that developing among our providers enough modality to have it really be effective. You know, is going to be fancy at best. So, well, you know, all advances that happen in medicine eventually do find their way, you know, into the pre-hospital environment. You know, just raise the age old question. It can be done, but should it?
I think that's a very valid point, and I think that that's one of the reasons we need to kind of pilot it in our system and see how it works and how it affects these different things. I do think that there are other uses besides just the fast exam, which could be done quickly, which actually might benefit in the treatment of patients. You know, giving high amounts of fluids and sepsis now, and we're questioning Lasix in CHF patients. You know, having a quick view might benefit in those patients. Dr. Harris, and Dr. Isaacs, Paul, and then David.
Conversation or particularly about the recommendation for resuscitation is really sort of test out cardiac scans, so they're not. So I think this one thing that really have.
So Dr. Isaacs mentioned there's no treatment decision, or there's no treatment. And I would urge all of us to do this as transparent as possible, as it's inherent that taking a study will change a treatment decision by a provider. So putting these devices on the truck will change treatment. And now my fear is you have a device that has not part of the curriculum or the state card being used to change decision making. So the quality process and the transmission process and the interpretation of said images, it can't be assumed as a physical exam. No one is taught how to use an ultrasound to maintain their state card. So deploying an ultrasound to make that decision making because the device is in your hand. We're not even allowed to interpret EKGs in this city. You have to ask for EKG to be approved as a STEMI before you should dare roll your wheels in this city. While we know that they can take the EKG, the state scope of practice says they can interpret it, they cannot act on said EKG. The same level of concern about ultrasound should be applied here. And if it requires going to the state in a fully transparent manner, we absolutely should do that and do it well to enhance this process going into the provider's hands because they deserve it. But to do it halfway, I fear for the whole project being shut down.
David? You had,
I was
oh, you want to go?
About being transparent, I think it's being part of this, contributing, sharing things, and always been transparent. It's not about being transparent. It is an assessment tool, not treatment. I agree. And also to Art's point, you know, the best example we are very fortunate on in terms of the trauma centers and short transport time is more looking at the lung exam Whereby, and would that affect treatment? But it's always going to just go by this incorrect. You can allow G's or us. That has to be, it's not for us to be able to engage. That's the operation.
And then
Years ago, Kevin Chase. In Mount Sinai.
no, there is, I think, significant evidence that it's feasible to do. I think in our system, with our operational constraints or environment, it might not be the most beneficial in our transport time. But I agree, it's definitely feasible. There's a feasibility study that it did. John?
So healthcare changes. So I think that taking a broader view, trying to do this now is a good idea. So that we're thinking it and give people the ability to work together and learn is very valuable. I'll give two points. One is that in terms of the training requirements, which is by far the hardest part right now, I think it's extremely likely that within 3 to 5 years that there will be AI for ultrasound will help guide and we're working with GE and a few others exploring how that works, trying to understand that. So that would change that component of it. And we had just with a couple of our medics and one of our medical control docs who's ultrasound trained, a recent kind of training, kind of just exposure, just to kind of see kind of what the response was, right? I mean, part of this is what do our paramedics think about this? And a lot of them came in very skeptical, which is pretty much every paramedic is skeptical. But they actually walked out, a lot of them actually being really excited to have this mentality in their hands. So I do think it's important. I think that we're really talking about a 10-year road, and I want us to imagine there's if it can exist, it will, that there will likely be a handheld device that will plug into whatever device that they have that will help them obtain images and likely interpret the images in potentially in a healthcare system where more and more people are staying home sicker, where EMS is a part of their care. So if you think about it that way, I think this is a really important initiative, and I'm glad that we're undertaking.
Yeah, I definitely think that, as we look towards the future of EMS and, not just as a transport entity, but as a treatment entity, both in the pre-hospital setting, home hospital and all this stuff, I think that it is important to look at these items. But I do think we have to do it in a process that ensures that the standards that we are setting aren't being missed because we're adding these devices to our system. So we've always designed our protocols where the standing orders take approximately 20 minutes. It has changed over the course of time because there are more standing orders, there's more things they have to do. But adding a modality in a patient that might be borderline sick and now this causes a delay might be problematic. And I think we have to do it in a very controlled way to ensure that there's patient safety. But that said, it was sent out and we will get feedback, and anybody interested, there is actually a physician who has offered training services. That information can be made available to everybody. I didn't send it out as a general rule because I don't think advertising for any particular person is appropriate, but it's definitely somebody who, if somebody's interested, can reach out and we will make the contact available.
So the last thing is REMAC oversees more than the 911 system. So I would urge everyone to think about non-emergent calls as being part of this as well. And if any of us has ultrasound training or predilection for its use, we should be leading that training, not someone far into our group.
Correct. Any other new business? Seeing none, I will entertain a motion to adjourn. Anybody? Motion? Okay, and what-